Thanks, Harry, colleagues, ladies and gentlemen. It's a privilege and pleasure to be in Maastricht. And I have to say, I like the style and the format and the culture of this meeting, which is obviously not the biggest in the field, but it's very intense, and you are very close to the procedures, and there is a lot of interaction, there's a lot of discussion, and it's a relatively wide range of people here, from cardiac surgeons to electrophysiologists. So this is really a great meeting. Thank you. This is also a great topic. All you want to know about ablation. You can talk 5 minutes or 5 hours on that topic, cover 2 or 22 fields that you would like to touch. And I was struggling a little bit with the topic in the decision, what the hell am I going to tell you? What you would like to know about ablation. And then I came up with the following solution, and I hope that you like it. If not, I cannot change it anymore. Honestly, forward is like the green one? Yeah, the big green one. The big green one does not work. Okay, we'll see. With the following, I selected 3 topics that I personally consider interesting in the field of catheter ablation. Where do we stand? Where will we go? And what's going to be the role of catheter ablation with respect to heart outcome parameters like stroke and especially mortality? What can we expect? And I selected a couple of slides that point out the current status of knowledge, and I would like to supplement that with my personal view on the issue. And I kindly ask you, whenever you think that something is more than controversial, what I'm going to present to you, please approach me, and even during my talk, and come up with your questions and criticism. Okay? That's exactly what I did. Mm-hmm. Okay, no problem. So we start without slides, and I give you the slides. I'll give you the slides in a minute. Here we go. So these are the three topics that I wanted to discuss with you. First of all, I would like to raise a little bit your interest on. Thank you. Great. Raise a little bit your interest on outcome of catheter ablation. I think it's very important to really reconsider on what we can do in the cath lab, what we cannot do in the cath lab. And to put it into the scope of this meeting here, we started in Leipzig in the operating theater with the treatment of atrial fibrillation with Fred Moore almost 15 years ago. 1,200 patients were treated in 2 years intraoperatively. Then we left the operating theater, and I have to say we came back to the operating theater because there is a subset of patients that may be treated better and more successful in partnership with our friends from cardiac surgery. So we continue to do cardiac surgery guided ablation of atrial fibrillation. If you look to the cath lab and to the results that have been reported from clinical studies in the field of catheter ablation of atrial fibrillation, it's a little bit confusing to get a clear view on what is possible in the hand of the interventional electrophysiologist. And this is because there are no good standards for reporting the outcome of clinical studies. And there are so many different factors that influence the outcome of clinical studies, the outcome of catheter ablation, that are not adequately taken into account in most studies. What defines the risk of recurrence? The techniques, technologies, the operator, the endpoint selected, the patient characteristic with the type of AF, concomitant cardiovascular disease is important. Most importantly, the follow-up and the intensity of follow-up and the quality of follow-up. And the painful thing regarding follow-up in AF patients is the more you work, the more you do, the less good your results get. Because the more you look, the more recurrences you get, and it's very painful. You work harder and harder, and you get better, you get worse and worse. This is really, it's painful. And the modulating factors, progression of cardiovascular disease, and concomitant drug therapy. And it's really important to understand that all these factors are not isolated, but interact with each other and define the risk of recurrence. So it's very difficult if a patient sits in front of me and says, "Doctor, if you do it, what will be my success rate?" To say it's 73%. No, you cannot do that. It's very difficult to predict. You can come up with some statistical expectation of what the outcome in this patient will be. I will share with you now some of the results that have been reported over the last years. This is one study, the one slide that has been shown thousands of times, indicating that antiarrhythmic drugs and radiofrequency catheter ablation are so significantly different, such a huge difference with respect to efficacy. I can tell you this is not true for real-world electrophysiology. It's true in the frame of these particular studies because these studies compared the following. They did not compare the potency of antiarrhythmic drugs versus the efficacy of catheter ablation. They compared patients that had failed antiarrhythmic drug treatment with catheter ablation. So you compare a previously failed treatment strategy, which is very likely to fail again, with something new. You know, this is a little bit unbalanced, a little bit unfair, or at least it needs to be clearly mentioned. So if you compare something which has been proven to be lousy with something you expect to be good, you come up with these figures. It's nice for us as interventional electrophysiologists to present these figures. I mean, we feel pretty strong showing these figures, but as we will see in a minute, there are certain limitations. If you sum up these figures from other studies, and all these studies that you see here had the same infrastructure, the same structure. It's always failed antiarrhythmic drug therapy, 2, 3, 4 courses. With catheter ablation, you come up with an odds ratio of 10 in favor of. This is not difficult. It's not a miracle. It's simply common sense. And if you look to the results that are published from the real world, you get different impression. This is from the European Observational Registry, patients taking from institutions all over Europe, 20 patients included by dozens of institutions. I think 60 institutions participated, real-world data in paroxysmal and non-paroxysmal AF, and you can see that the results here are quite different from what has been shown in previous slides. This is real-world, and if we go even closer to the real world and take a look to the studies that assessed the efficacy of catheter ablation of atrial fibrillation as first-line therapy, this is a fair comparison. First-line drug versus first-line ablation, you see that it gets difficult for catheter ablation. Mantra PAF published in New England Journal of Medicine, and the key centers in the field participated in that study. European key centers in the field. And there was no statistical difference in the primary endpoint of the study, which was total burden of atrial fibrillation. There was no difference between flecainide and catheter ablation. There was also no difference with respect to complications, which is good for an interventional therapy operation. At 2 years, there was a statistical difference in the burden, and we will see in London this year the 5-year follow-up of Mantra PAF. I don't know the outcome. It's going to be really interesting to see what happens during longer follow-ups. The message that we took from the RAFT trial from Andrea Natale, the key centers of catheter ablation in North America. We are not talking about part-time electrophysiologists. Key centers are presented here. And as you, can we go back, one back? If we go, if you compare the efficacy antiarrhythmic drugs, the recurrence rate, it's not 60% difference. It's 10–15% difference. Needless to say, the benefit of catheter ablation is for quality of life, no drugs, no atrial fibrillation, good exercise capacity. This is there, no side effects. But it's not such a strong difference when you go into a fair comparison. A quick look to complications. Complications are there in all interventional procedures, and they are there for catheter ablation as well. There's a measurable mortality, even in the cath lab, which is below 1%, but it's not low enough in order to be not measurable. Here in Leipzig, we had a mortality. This is Douglas. These are Leipzig data. We had, within 21 days, we had a death that occurred due to an arterioesophageal fistula. And the overall complication rate that are reported here between 2.7 and 3.9% from mostly key centers underestimate the true complication rate, which is 6 to 8% for catheter ablation. And I think it's important to understand that. Quality. Ralph and myself, we discussed this particular study. Quality in the field of catheter ablation of atrial fibrillation. On both sides of the Atlantic, there is an issue. In North America, 80% of all AF ablation procedures are done in centers with less than 25 patients per year. I couldn't believe that, but it's true. And this is something that is unacceptable when it comes to quality. Needless to say that among these operators, there were some people that can execute quality, high quality, even in that setting. But as a rule, this is no good. You will see data from Germany showing that it's not that much different in Germany. And when it comes to complication, the complication rate is almost twice as high in this registry data. So the true complication rate, you know, everything which has been overlooked in registries, is higher than this one. And look to the huge differences between the experienced operators and the non-experienced ones. And take this as a strong call for normative regulation. You here in the Netherlands are by far more advanced than we are in Germany. In Germany, it's a wild market. Everything can do whatever he or she believes is good to do. It needs to be regulated because healthcare does not follow the rules of the free market. We do not buy and sell, we treat, and we need to look for quality. This is Germany, data from 2010 showing the distribution of centers performing AF ablations, and as you can see, there is a considerable number of centers that is below 100 cases, almost 2/3. I don't think that this is good. It's not good for the center. It's not good for the patient. The only profit is for the ego of the doctor doing these procedures. So we move on and take a look to two specific new technologies that I considered interesting, and I would like to give you my personal perspective. What will be the treatment technologies, strategies for the future? We have seen a lot of fascinating technologies during this meeting from the field of surgery, from the field of interventions, and I would like to share with you my experience and my impression on hunting the rotor in the EP lab. This is Sanjay Narayan's initial report on rotor mapping and ablation in the EP lab. I tell you, I'm in the field 30 years, and there were few things that really surprised me. This was among that. It was really among the surprises where I thought, goodness, I did not believe that this is true. Sanjay Narayan, I know for 15 years. He's a very reliable, he used to be a very reliable basic scientist, and he's a very reliable clinician. The guy is really trustworthy. So when he presented these data that you can terminate long-standing persistent atrial fibrillation with pinpoint lesion, and he showed that during live cases. Many of us have also seen live cases where it did not work, but there were live cases where it terminated long-standing persistent atrial fibrillation with pinpoint lesions. This was really fascinating. And I would not have expected that this is possible. This is, the technology is based on the identification of so-called rotor activity by using very sophisticated algorithms that take their data from baskets. Can we go back? I was pushed the wrong button, sorry. They take their data from baskets that are placed in the right and in the left atrium. These unipolar and unipolar electrograms are taken into the system. They are transformed. It's called Hilbert transformation. I have no clue what that is. And with this Hilbert transformation, they're able to identify rotor activity and can display that color-coded. I will share an example with you. And when you go there and you ablate there, the AF terminates. This is from our Leipzig experience. You see here integrated in the NAVAC system, left atrium, right atrium. Mapping of rotors was performed in the right atrium. There is a series of lesions deployed there. Now the catheter is in the left atrium and mapping is continued there accordingly. This is what you see on screen before the data have been transferred to the system. It's useless to try to understand anything from these data, and the data go like this into the system, and what you get out looks like this. This is now the optical display. It should be the optical display of the Hilbert transformed data taken out of the baskets. You see here the left and the right atrium and the activation patterns according to the transformed data. And there is a spot that repetitively is activated like a rotor. It's visualized. It's, I don't know how to say that. There is no algorithm to visualize that, which is really solid. You look to the screen and you have to do it for minutes, and then you see that there are certain activation patterns that repetitively occur. They are currently trying to build it into a software algorithm that assists you in finding the so-called rotors. Then you ablate there. And we have treated 20 patients, and I will show you the outcome of these 20 patients after I shared with you what Sanji has reported. You can do it with the Kato system as well. This is treatment in the left atrium. Most of the patients that undergo this procedure have been treated with pulmonary vein isolation on top. This is important to understand. Data from Sanji Narayan showing that patients that were ablated guided by firm mapping plus pulmonary vein isolation did significantly better as compared to the rest of patients that only received pulmonary vein isolation. There is one thing that I never understood with this study. Why the hell are the results of pulmonary vein isolation so bad in this particular study? If you compare it to other studies that had only pulmonary vein isolation as an endpoint. And I think there must be some bias in there. If you compare the patients where rotors that have been actively approached or that were coincidentally approached in the blinded arm of that studies had been ablated, all rotors, some rotors, no rotors, you see that the difference is huge according to the analysis of their study. When it comes to long-term outcome, and this is 3-year follow-up, recently reported again by Sanji, the patients where the rotors had been ablated, it's no longer 90%, but it's 60% as compared to patients where no rotor was detected, almost recurrence in all patients. So it's a little bit of a black and white presentation of these data, because I have not seen patients that underwent pulmonary vein isolation that had almost 100% recurrence. So there must be some bias in there. Yes?
He used continuous monitoring in all patients, so any kind of AF recurrence has been documented.
He used in most of the patients continuous monitoring. And openly I said he's a reliable guy. The methods they applied are strong, but I do not understand everything fully because it contradicts so many other studies. Maybe that the other studies were a lot weaker with respect to the setup and the data reported. We did 20 patients with the TOPRA system. We could not terminate a single patient, not a single one. We even did not see an increase in significant increase in cycle lengths, not in a single one. And yesterday, I saw the long-term outcome of these patients. They were cardioverted, they were put on the road, all patients with long-standing persistent atrial fibrillation, freedom from atrial fibrillation, 86%. I was shocked. I was really shocked. I did not believe that. I did not expect it. I was ready to sell the system. But it seems that it's a small patient cohort, but it seems that there is something in there and that there is more in there than I initially believed. The next technology that is really driving me and is fascinating me is this one. It's MRI visualization, and I would like to guide you from MRI visualization to MRI interventional suites that I believe will be the future of electrophysiology. Why do I believe so? It's just common sense. We will see substrate-based arrhythmias in the lab. We see almost exclusively substrate-based arrhythmias in the labs. The WPW syndromes, they are dead all over Europe. We don't see them anymore. A couple of AVNRTs, a little bit of flutter, and then it's AF and VT. And both arrhythmias are substrate-based arrhythmias. Fibrosis or substrate changes play a key role. I would not guarantee that everything that Nasir Marouche reports will be reproducible. But in principle, I believe it's true. In principle, it's true that the more advanced the changes of the substrate is, the more difficult it is to treat the patient. This is one side. The other side is, if the substrate is important, it may be the case, and there is likelihood, that substrate-based treatment, personalized therapy, has advantages over one-size-fits-all. We have learned from the STAR AF2 trial, which was mentioned by Karina in her talk, that adding lesions in all patients does not make sense. Cafes in all patients does not make sense. We will see in one of the key journals another prospective randomized studies very soon, Minimax trial, interesting name, Minimax, a trial, randomized trial from Australia comparing different treatment strategies, and as with STAR AF2, the patient group that had less intense treatment, least intense treatment, had the best outcome. So this should really make us reconsidering, and Karina mentioned it, especially when it comes to guideline recommendations, we should roar a little bit back with respect to treatment intensity. Why do I believe that MRI visualization will become a key role? I believe the next decade in cardiovascular medicine will be the decade of visualization and delivery, both. See better, see earlier, detect preclinical states of disease, go to personalized treatment and bring something in there. A drug, a poison, a stent, a valve, whatever, bring it in there. See it and bring it in there. And it will be true in EP as well. We make a very small side step only for 20 seconds to urology. This is treatment of prostate cancer in the MRI with thermal mapping, with thermometry. You can see temperature gradients in the MRI. And now think about, now it's common sense. Think about ablation. What is ablation? It's cooling down or heating up. And then you see online the tissue effects. You don't need any more surrogate parameters like contact pressure or like temperatures that are reflected and cooled away and flushed into nirvana. You simply need to see the lesion. You induce a lesion, you see the temperature gradient, and you know this is enough, I stop, and then you analyze and you see the lesion. We go back to the heart and you can nicely see the lesions. We went into the field a couple years ago and have meanwhile treated 30 patients in the lab. It's very well feasible in the MRI. Completely treatment in the MRI. Patient in, treatment, patient out. Nothing works for all patients. It's complex to set it up, but it's feasible. And this is isthmus ablation in the MRI. This is the first patient that has been treated. And now we are moving to active tracking from the right atrium to the left atrium, and you can use existing technology in the MRI comparable to what we have in the EP lab. Biosense Webster Cato system for the MRI is very much advanced. NAVAC system to be used in the MRI is very much advanced. Catheters are there, sheaths are there, wires are there, needles are there, everything is there. And this is the new scanner. It has been built up 3 days ago in EP, in Leipzig, a Dutch product, I have to say. Will be started in April 24th for interventional electrophysiology, exclusively for that purpose. And I tell you, it's gonna fly. I'm so much convinced. So the last 5 minutes of my time is the question, will catheter ablation have an effect on outcome measure? And I would like to concentrate it on mortality. Nikos Douglas has analyzed that a couple years ago, all the studies that were available. And in these studies, there was no effect on mortality. It's difficult to find an effect on mortality in a subset of patients that have atrial fibrillation, but no significant comorbidities, because there will be not many events in this patient population, and the cohorts were too small in order to come up with a meaningful result. I believe we have to take a look to these patients, to heart failure patients. Heart failure patients have a measurable, still, despite all pharmacological, non-pharmacological treatment we apply, they have a measurable mortality, a high mortality. So let's take a look to what catheter ablation of atrial fibrillation can do to these patients. And I see a key application of ablation, catheter ablation, and surgical ablation in this subset of patients. This slides I've always called the miracle of Bordeaux. You have a patient with highly reduced left ventricular ejection fraction and atrial fibrillation. You ablate him, and ejection fraction normalizes. Too good to be true. There is a certain degree of selection bias in these studies. It's very difficult to reproduce it when you only select in heart failure patients to see that. These are patients with tachycardiomyopathies, and they are there, but it's a subgroup of patients with heart failure and atrial fibrillation. If you select coronary artery disease patients with AF, you will not see the same results. But it's needless to say, it's impressive to see the increase in ejection fraction. If ejection fraction is the strongest parameter for mortality, and it is, the only predictor we have, and an increase in ejection fraction reduces mortality, this must be mortality relevant. And I will share with you a couple of data. Overall success rate in heart failure population that underwent catheter ablation, it's quite good. I would like to recommend reading this work, which summarizes the current status nicely. Difference in ejection fraction reported in these studies. There was an increase in ejection fraction of around 15 to 20%, which is significant. It's really significant in these patients. These are Leipzig data, increase in ejection fraction. And this is a study which has been released during the ACC, the ATTACK trial, showing, comparing catheter ablation with amiodarone in heart failure patients with atrial fibrillation. And I will close with these data. It's 203 patients which were randomized one-to-one to catheter ablation versus amiodarone. Primary endpoint was recurrence of atrial fibrillation. Secondary endpoint, hospitalization, and they took a look on mortality. With 200 patients, mortality, even in heart failure patients, cannot be the strongest outcome measure because it's underpowered for mortality. So, but it's really interesting. Amiodarone catheter ablation, you can see that the patients with in the catheter ablation group did significantly better with respect to rhythm outcome. Ejection fraction significantly improved by 10%, not by 40%. I think these results are really reasonable. And they're also improved in the amiodarone group, which has been rarely shown, but it also makes sense. It fits into my view on the global view on the picture. Minnesota living with heart failure score significantly better improved in the catheter ablation group, and at over 2 years follow-up, hospitalization was 31% in the ablation group, but 57% in the drug group. All-cause mortality was 8% in the ablation group and 18% in the drug group. I think that this is the next field we should go in. There are a couple of randomized trials on the way. AMICA is on the way. Castle AF is on the way. Both are currently in interim analysis, and I think we will hear the results, interim results, maybe final results during the ESC Congress in London. These were my key messages on the topic. All you want to know about AF ablation. Thank you very much.
Excellent. Thank you very much. I at least enjoyed your presentation very much. And it's open for discussion. Rolf, please go ahead.
Gerhard, great talk as always. I just wanted to know, I'm interested in your view on Sanjeev Narayan's work. Because our group, we've mapped human AFib really since the early days of the Maze procedure back in the early 80s. We have a lot of database of that, and we're here at one of the world centers of mapping with Mertz Alessi. And I will tell you, at least in our experience, and we've done now a lot of ECGI and body surface mapping with Yoram Rudy and his group, and while you rarely see a stable rotor, it is such a small percentage, what Sanjeev is seeing. And I share your respect, and I think Sanjeev's a fantastic scientist and a brilliant guy. But how do you put that together? And I don't know if Dr. Alessi, I haven't, he's what he would say if he was here, but I don't think he's a fan of this idea of a stable rotor, to say the least.
I know what he would say.
Yeah, I know what he would say too. I wish someone maybe could take his, but we haven't seen it either. We rarely see it, maybe in 10%, but in the more common is multiple mechanisms and very unstable mechanisms that we see in patients. So what's your feeling, and why the results at least seem to be holding up?
I have no clue, Ralph. I share your reservations. You ask the right questions, and I cannot provide a good answer to your question. I always had my problems, and I think we have the same perspective on that. In the big congresses, for the last 3 years, you always had the three same talks. It was Pepe Khalifa who gave a talk on rotors on a subcellular level. Then the next talk was Sanjeev Narayan. He gave a talk on rotors as identified by mapping from unipolar cardiac electrograms. And the next talk was then given by the Bordeaux group or by Karl-Heinz, presenting on rotors from body surface mapping. And they're always talking about rotors, and everything seemed to be beautifully in line. I never understood that. I never understood whether or not they're taking from the same, completely different, or comparable or related phenomena, but I have the same thoughts and reservations that you pointed out. It does not seem to be in line. I don't understand. I really don't understand that. Then we talked to Sanjay, and Sanjay said, okay, join us for the project. I said, Sanjay, I don't know. And he said, okay, do it, Gerhard, do it. And I said, okay, we do it. And we did the first 20 patients. And I was in the lab, and I saw the procedures. It was done by Philip Sommer, single guy, experienced guy, has done thousands of AF ablations, good guy. And when he came back and said, we have not been able to terminate a single patient, not a single one, Ralph. We not talk about termination rate of 20%, zero termination rate. I thought, okay, at least it's not reproducible, what they do. I mean, we had the same issue with Nademani and cafe ablation. In Wee's lab, the patients terminated like hell, and whenever it was done outside Wee's lab, nobody terminated. And it's a little bit the same here in this setting. We will analyze and try to understand why the results, the long-term results, are so good with 86%. I do not have a good explanation for that. Philip presented it yesterday to me. We have the German Society meeting next week. Then he will talk about that. And he said, that's it. And I said, no, you're kidding. This cannot be true. Yeah. We will further explore and then report, and then we will see. But it's not in line for me as well.
One of the things I was wondering if you've done, if anyone's done, if anyone knows, because one of the skepticism, I think, of this is this proprietary algorithm where they take what looks like chaotic electrograms and recreate that little, rotor. But, you can't really deconstruct it. Do you know, has your group or anyone compared that with more traditional mapping mechanisms to see, you know, what is the comparison? Because it's proprietary and it's hard for us to get it figured out. So I just was wondering.
Karl-Heinz did that. Karl-Heinz Cook did that, and they have the body surface mapping system from Amiran Ravishvili, the AmiCard system available. So they have body surface maps. They from the same patient, body surface map, and they have maps from generated from endocardial electrograms, and they were not in line at all. There was nothing that you can say, okay, there is a body surface rotor. These rotors are frequently unstable in time and location, while these ones seem to be stable for days and hours. I have not seen any results obtained in patients where you map a rotor and then you cardivert, you re-induce atrial fibrillation, you do the same analysis again, and you end up at the same site. So there are a lot of open questions, and to me, it is not clear, although we have seen these surprisingly positive results, it's not clear what the role of this technology will be in the future.
Carina.
You had 86% success rate with a long-standing persistent, but you didn't have a control group. No,
needless to say, there was no control group. That were consecutive patients. Most of the patients had at least one, most of them 2 or 3 failed previous ablations. So it was a negative selection group, but it's not a randomized trial, it's observational, and all this limits the results. 10 out of the 20 patients all of the patients were cardioverted at the end of the ablation procedure. 10 of the patients were again cardioverted within the first 7 days.
Did you look at it more from a mechanistic standpoint? I'm thinking of if this is an electrical or excitation phenomena, or if it's an anatomical. For example, you could test the system if you pace from one position at a very, very high rate and then record and see if you get the corresponding rotors or if you do not. And pacing from different positions, like from the scar-related areas and non-scar-related, did you look at that kind of?
No, we haven't done that, and I'm not aware of such basic studies that have been performed by others. Okay. I really don't know. But it needs to be done, and it would make sense in order to get a little bit clearer insight into what the system at the end of the day displays. I share another secret with you. When you come into the room, it's between us. You come into the lab and you see the display monitor of the Topera system, and you look there. If you ask 3 people, where's the rotor, you may end up at 3 completely different sites. Which I never.
Isn't that characteristic for a rotor?
I don't know, but we investigate. We measure, and then we report. And this is what we did again, and this is the outcome. And I have no good explanation for that.
Maybe the Maastricht experience, Bart Maassen.
I don't see anything. Uli is not here.
Well, you're the master now, so come on.
Dr. Hindricks, great presentation. Very enthusiastic, very convincing. I heard that the Topera system even shows rotors when it's off, but I cannot confirm that. No, I think Marius would say analyze so many fibrillation maps, and I never observe a rotor. I think the big difference is he used the Hilbert transform, which is, of course, a mathematical transformation to be able to perform phase mapping. And we now soon we will publish on this because it's very interesting. It's a question of perception. It's a question of how you analyze the data, and you can visualize rotors, of course, depending on how you handle your thresholds. I think the most important thing is what the clinical results are. If there are rotors or no rotors, I don't think that's that much important. If you have a system which is able to produce very good results, if it's ablation of a rotor or something else, then that is very valid. And I think we should spend much more effort on analyzing what is going on more in detail. And I think this can be done by comparing technologies and analysis options.
Yeah,
Huh?
I share your points. I can recall that we had a fascinating talk during last year's Boston AF meeting in Orlando from a guy, I forgot his name. He analyzed, he talked about data transformation, phase mapping, and what you can take out of it. And he exactly said what you just said. Mm-hmm. It's just simply a matter of how you handle the data set. You can make everything out of it. So this makes it even more complex and complicated to grade on the value of the technology. I think what Karina said was very important. This is consecutive patients. It has nothing to do with prospective, no study, no control group. In a group of 20 patients, there is a high likelihood that a significant portion may have happened by chance, period. But it is in a way in line with what these guys have reported. It does not, at least not contradict what they have reported. And I really would be interested to understand a little bit better how this should work, or how it works.
Ironically, is when you see these cases, some of it organizes to areas where you'd almost expect. You know, like one was a posterior wall, one was in a focal area of ganglia. So like you said, is it chance, or are we just happening to hit other substrate that we had? And the other issue is just the adaptability of the technology. That's going to be the biggest hurdle for it. Like you said, the usability for centers to use. So I think that's another big hurdle. Until he can come up with something, like Ralph was saying, like something makes sense when you can have it, take it apart, and put it back together again. Until that clicks in people's minds, I think it's going to be an issue broadly. Yeah.
This technology needs to be assessed in the frame of a prospective randomized study, needless to say, with strong follow-up. But as you said, Sanji usually has a very strong follow-up, at least above average. And it has to be done in a study design where the pulmonary veins are not touched. Then we see. Or you can do 3 arms, say pulmonary vein isolation versus pulmonary vein plus rotors versus rotors only, and then we should see. And if you make the recurrence of any atrial arrhythmia an endpoint, at least according to these results in the pulmonary vein group, you should generate enough endpoints in order to keep the patient cohort reasonably small. There is one study, an observational study going on, looking only for rotor ablation, but I have not seen the results. Karina, have you seen anything from Sanji? Only rotor ablation in paroxysmal AF. They do it, but I have not seen any results.
Well, I have 2 questions, in fact. So what I would like to know about ablation, which I don't know. I hope you like it. So the first question is on, when you came into the lab, the EP lab, for the very first time, you were flabbergasted about what those people behind the screens, or it was paper yet?
Yeah, it was paper.
What they saw.
Yeah.
Which you couldn't see yet. So I'm talking about the, see what cannot be seen. And whilst you were longer in the lab, you saw, you started, well, you could see what the others saw.
Yeah.
And then you also realize in a moment in time that you saw things, especially when hitting the button and ablating, where you saw something you couldn't really tell. Must be something. Mm-hmm. I'm not going to check. I'm not sure why, but I see it, and you are effective there. So now my point is the following. So it's a little in defense of Nadamani's work. There's cafes, and there's cafes. There are cafes who matter, and there are cafes who do not matter. And apparently, Nadamani is able to see, to differentiate that from the screen. And that's something maybe, and that might be, you know, the rotor business, there's a machine in between. I don't like that too much, because that's what you're saying. You can turn the knobs and you see something differently. But looking at electrophysiological signals might be, well, there may be things to be seen which some see and others don't.
This is a very important remark, Harry. I'm thankful for the remark. I did not want to induce the impression that I consider we Nadamani as unreliable, and this is an important point. It's also true for Nasir Marouche and this decaf stuff. Yeah. If we cannot reproduce something that others can do, we have to leave at least a small rim open. We can exclude that they are smarter than we are, because nobody's smarter than we are. But we have to leave a small rim open that they can do something or can see something that we cannot see. That Nasir Marouche, because he has 20 people looking at a single MRI, sees something that we cannot see, and that we, Nademani, whom I highly respect as an electrophysiologist, can see something in cafes which the Biosense algorithm or the St. Jude algorithm simply misses, and which may require a high degree of experience that you don't have in your genes. You have to learn it, and that we never learned it. It's a very important remark.
My last question would be on the heart failure thing, and ablation, ablation leading to an increase in ejection fraction. It may be more, it may be less. My point is, it's on ICDs in these patients. So my point is, what's your opinion about if the AF is there and the EF is low, let's say 30%, and you do not have a reason for the low EF, so there's not coronary and valvular disease, no hypertension, would you, what would you say to all the people who put in an ICD in that patient? And the rate is, let's say, 80 beats per minute.
It depends on the substrate, on the ventricular level and the.
Well, the MRI. Let's say the MRI is you know,
okay,
as far as it can be made with AF.
Then I would not put an ICD in. I would not put an ICD in. I think that for a significant subset of patients, the value of ICD therapy is overestimated. I say that with all respect for the fact that the ICD has saved many lives in preventing sudden cardiac death. But if we look especially to patients with non-coronary artery disease, we have to realize that we do not have a single strong study supporting the effect of the ICD on total mortality. If we now assume that in a subset of patients, left ventricular ejection fraction will improve after the ablation procedure, then it must have first an impact on mortality, and second, it must have an impact on the need for ICD implantation. Needless to say, we have to go into trials and studies in order to prove that, but if this is not true, we must rewrite most of the books of cardiovascular medicine, and I don't want to do that.
Thanks very much.
Okay.